Welcome everybody to this week's CITP lunch seminar. Our speaker today is another one of our distinguished faculty members, Janet Currie. She is the Putnam Professor of Economics and Public Affairs. She's the head of the economics department here, the director of the Center for Health and Well-Being, so obviously you have a lot of free time on your hands. She also has many of the elite credentials in our field. She's a member of the Institute of Medicine, the American Academy of Arts and Sciences, and a long list of other things. But rather than recite more of her credentials, I'd like to pass it on to her and let her talk to us about big data and privacy and pediatric healthcare. Thanks.
Okay, thank you very much for inviting me to be here. This talk is based on an article I wrote a couple of years ago for pediatrics, trying to explain to pediatricians what some uses for big data might be. And the starting point for the article was the observation that there's a lot of discussion in medicine these days about big data, but usually what they're talking about is genetic sequencing or biosamples or something really trendy. And there's a huge amount of administrative data that the healthcare system generates that you could also think of as big data. So just some examples of that are vital records, like birth records and death records. Every time there's a birth, every time there's a death, there's a record filed. Those records actually have a lot more information in them than people think. So when you think about birth records, you think about your child's birth certificate and has your, the parent's name, where you were born, the child's name, and that's it. But actually the record that the government has all kinds of information about risk factors for the pregnancy, socioeconomic status, things that were done during the delivery. And that's the source of all the information that we have about births. Like when you see a thing that says teen births are going down, that comes from vital data. When you see something about how the rate of low birth weight is changing, that comes from those data. When you see controversies about C-section delivery, that comes from the birth data. Okay, so that's just an example. Another example is hospital discharge records. Every time somebody goes to the hospital, whether they go to the ER or whether they're actually admitted overnight to the hospital, there's a record generated. That record goes to a state agency, and the states use that for regulating the hospital system. Okay? A third example is just insurance claims data. So most people have health insurance, and every time they see any kind of medical practitioner, there's a claim generated, and that goes off and lives in a database somewhere. So if they were a working age adult, most of the time that would go to a private insurer like Aetna or United Health. If they're elderly, it would go to the federal government because the federal government runs the Medicare system. And if they were a child, many children are covered by the Medicaid program or by different state public health initiatives. And so the claim would go off to that public database. So there's just reams of health data floating around that's being generated all the time by these systems. So what I'm going to do in this talk is first think about some of the useful things that you could do with that data, and then I'm going to come back to the privacy issues and issues about who has access to that data. So just in really general terms, one of the useful things about administrative data is it covers everybody. So most of the time in a medical study, if you pick up JAMA, you'll read about a lot of studies where they have 100 people and they were selected somehow of people walking in through the door, and you don't know if it's representative of the whole population. Okay, but in the administrative data, typically you have the whole population, so you don't have to worry about whether it's representative. You also have all of the information about everybody, so you're not worrying about recall bias. And if you want to follow people over time, you're not worrying about attrition, like the idea that some people will just drop out of your study. Okay, so there's some very big advantages. Other things that you can use administrative data for are linking individuals in the same family. If you wanted to do something like compare siblings or see whether certain conditions are passed from parent to child. Or you can link people to a geographical area. So suppose you were worried about pollution of some sort, you could find people who lived near the pollution source and see whether they had different outcomes than other people. So let me be a little bit more specific than that, and I'll just give you some examples. There's been a lot of controversy over many years on the topic of how much weight should you gain when you're pregnant. Okay, so any woman here that's been pregnant knows that the medical system kind of obsesses over this, and the guidelines change periodically. So I first heard about this controversy at a planning meeting for something called the National Children's Study, which, if it ever gets off the ground, will be a very complicated, multi-million-dollar study following 100,000 children from the fetal period through age 21. So at this planning meeting, various experts were being asked, well, if we had such a thing, what could you do with it? And one of the people, David Ludwig, who's an expert on childhood obesity, said, well, one of the things we would be able to know using this data is whether how the weight gain that you gain during pregnancy is related to the child's birth weight. He said, we don't know that. So I came up to him afterwards and I said, well, you don't need the National Children's Study for that because the vital records say weight gain during pregnancy. So for every single birth, we know the weight gain during pregnancy and we know the birth weight. So, look, I could do this regression for you in 5 minutes and you would know the answer. So we did that, more or less. What we did was a little bit more sophisticated than that because we used a confidential version of the data where we could link siblings, and then we compared siblings where the mother gained more or less weight and said, what is the relationship between that and a high birth weight baby? So a high birth weight baby is over 4,000 grams. If you're over 4,000 grams, which is like 10 pounds, the baby's more likely to have to be delivered by cesarean section. There's more likely to be complications. And so this picture just shows the results for our study, which was published in the Lancet. And you can see that relative to gaining 8 or 10 kilograms, women who gain 24 kilograms have over twice the probability of having a really high birth weight baby. Okay, so this was the first time that had been demonstrated. Another thing you can see here is how small the confidence bands are. And that's because we have hundreds of thousands of pairs of babies, right? So you want the answer to the question, you can look at the data, you can get the answer to the question. Another thing that we did was to ask how the weight gain during pregnancy was related to the child's BMI later. So were big babies more likely to be overweight? And in order to address that question, we collaborated with some people in the public health department in Arkansas and linked the birth data to what they call a BMI report card that they do for every public school child in Arkansas. So in Arkansas, they measure the kids and then they send home these report cards that say, whether your child is overweight and you should do something about it. Okay, so what you can see in this graph, the one on the left-hand side is showing just the continuous relationship between the mother's weight gain during pregnancy and the child's BMI. And here, gaining 6 to 12 kilograms during pregnancy is considered the normal thing. So if you gain less than that, your child is going to be small. And if you gain more than that, your child is going to be larger. And then on the right-hand side, we're looking at the probability of being overweight. Okay, so here the confidence bands are larger. Arkansas is a relatively small state. But you can see you get a significant effect on childhood obesity if the mother gained over 18 kilograms during pregnancy. Okay. I should say one interesting thing about this data is we never touched it. So all of this analysis was done in what they call a data warehouse in Arkansas, where they have sensitive health data and sensitive education data. And so we directed a programmer who worked for the state to do all of these analyses and never looked at the data ourselves, which was actually fine with me because there was never any risk of disclosure or anything like that on my side since I was not handling the data. A more recent study that we've done is looking at the relationship between influenza during pregnancy and premature birth. So in this study, again, we were looking at siblings, and this graph shows what we found. So along here is the month of conception. So here is May, and you can see that what this shows is that babies who are conceived in May have shorter gestations than babies who are conceived at practically any other time of year. Okay? So babies who are conceived in May are typically coming to term in January or February, which is the height of the flu season. And I should say this is data for the northeastern United States. The reason why there's 3 lines here is because the blue line shows just the ordinary least squares relationship, not controlling for anything. The red line shows what happens if we control for observable characteristics of the mother, like race, age, marital status. And the green line is showing this comparison within mothers. Okay, so in this case, it doesn't really make that much difference whether you control that way or not. You still get this very clear pattern. And then over here, you can see the pattern in influenza patients at the birth month also peaks for babies who are conceived in May. Okay, so we looked at this and we thought, well, this looks like there's a relationship, but in order to try and prove that there's a relationship, what we did was make use of the fact that flu seasons have different strengths, and in particular, in 2009, we had H1N1, which not only was a really terrible flu season that particularly affected pregnant women, but it also had a peak that was much earlier in the season. Okay, so if you compare the 2009 epidemic to the usual flu seasons, here the blue line shows the usual. And so as usual, you have the babies conceived in May having short gestation. And this is showing the gestation in weeks, and then this is saying whether your gestation was less than 37 weeks, so whether you were technically premature. And then this is showing what happened in the H1N1 epidemic, where the peak shifts now to babies who were conceived in March, because these babies then were coming to term during the H1N1 epidemic. Okay, so we were able to show that influenza had a really strong effect on prematurity and might actually be responsible for a lot of the premature births. Now, my postdoc, Hannes, has been following up on this using Danish administrative data. And the really great thing about the Danish administrative data is that you can link all sorts of registers together. So what he's doing is looking at women who are actually hospitalized for flu in Denmark, and then following up their children to see what happens to their educational attainment, their disability status, their earnings. And he finds actually that children who were in utero when their mothers were hospitalized for flu are have 10% lower earnings than other children. Okay, so the reason I think this is really exciting is because it suggests that even common infections, if you have them sort of at the wrong time during pregnancy, could do significant damage to the fetus. And in the case of flu, it's entirely preventable. So only about 40% of pregnant women are immunized for flu, even though the CDC recommends it, because people don't like taking medications when they're pregnant. Doctors don't like giving flu shots to pregnant women. But our research suggests that it could have a really positive effect on the public health if this were to be done. Okay. A third example, as I mentioned, has to do with pollution. This is a toxic release inventory site. The Environmental Protection Agency keeps a database of industrial plants that emit toxics. And anybody can download that data from their website. So what we did, again, using confidential versions of the birth data, was link the pollution data to where people lived. And we were able to show a couple of things. So one really interesting thing is just that there's a really obvious pattern in the data that shows that Black pregnant women are more likely to be exposed to toxic releases than white women. Okay, so I thought this was very strong corroboration of the environmental justice hypothesis. And then we were also able to show that being close to an operating plant during pregnancy was related to a higher incidence of low birth weight. So that's what this table is showing. We're dividing people up into bins depending on how many meters away they are from a plant. This one has a very large confidence interval because there's not very many people who live right next door to a plant. But when you get to 1,000 to 1,500 meters away, you have a significant increase in the probability of low birth weight. That's true also for 1,500 to 2,000 meters. And then after 2,000 meters, it kind of goes away. So again, using this kind of data, you could show, well, yes, there's a negative effect on health, but also that the negative effect on health seems to be much less after about 2,000 meters. So you could answer a question like, if you wanted to have zoning to protect pregnant women, how far away should residences be from plants? Okay, so those are my examples. And you'll notice that almost all of them have to do with birth data. And there's a very good reason for that, which is that birth data is not covered by HIPAA. Okay, so HIPAA, the Health Insurance Portability and Accountability Act, applies to almost all health data, but not to vital records because they've been collected for hundreds of years and they were grandfathered. Okay. So that means that birth data, at least in some states, is accessible through a sort of normal IRB process. HIPAA, I was surprised to learn when I looked into it, actually does allow covered entities, which is almost all healthcare providers, to share de-identified data. The statute says that an entity is allowed to use a qualified expert to make a judgment about whether the data are sufficiently de-identified to be released to researchers. Okay. But I think the problem is that that's so vague. It doesn't say, what is a qualified expert. It doesn't say anything about how you judge whether it's sufficiently de-identified, that nobody does that. Okay. Instead, what they do is they use the second way to make their data de-identified, which is to remove 18 different categories of information, including the dates of service and the geographical location. So basically, they remove enough data to make it pretty useless for research purposes. So the Institute of Medicine has written several things about HIPAA. Their 2009 report concluded that HIPAA seriously impedes research without adequately protecting the patient's privacy. Nevertheless, the Department of Health and Human Services in 2011 asked for public comments on a proposed reform of the Common Rule. So the Common Rule basically says that you can share de-identified data. Okay? And the reform was to adopt the HIPAA standards for defining what de-identified data was, okay? Which would basically mean that you couldn't share any useful health data. Okay, so one important issue having to do with this data is the sort of patient privacy issue. Another really thorny issue involves consent. So most of the time when we have administrative data collected, all the examples that I gave, for example, you don't know that it's being collected. You don't know that it's sitting, if you were born in New Jersey, that it's sitting in Trenton somewhere. And you don't know what they're going to do with it. Okay? Nobody ever asks you. From a research perspective, as I said, one of the really important things about the data is that it's comprehensive. So if you think about, okay, what would happen if there was a consent requirement? So now I have 4 million births every year in the United States. If I want to use birth records, I have to go back and consent all of those 4 million people. And if I want to do it for 20 years worth of data, that's 80 million people that I have to consent. Obviously, that is not going to be feasible. And another problem is that even if it was feasible to contact most of them, some significant fraction wouldn't reply or would even say no. And so then you'd have a selected sample which would get rid of one of the major advantages of using the administrative data in the first place. Okay, so again, the Institute of Medicine has sort of thought about this issue, and they try and make a distinction between what they call interventional research, obviously when you're intervening with somebody, and research that is, quote, exclusively information-based, unquote. So they recommend that as long as the latter type of research involves sufficient protections for patient privacy, that it should be allowed without individual consent. A third issue that I want to raise, and then I'll conclude, just has to do with stewardship of scarce resources. So most medical research in this country is paid for by the public in one way or another. And all of this administrative data is also paid for by the public in one way or another. Every year, in my opinion, millions of dollars are wasted on studies where we already would know the answer if we were able to look at the administrative data. And if the existing data is sufficient to answer the research question, so in the first example that I gave, you want to know what's the relationship between weight gain during pregnancy and birth weight, you could know that without running the National Children's Study. Then I think there's a good argument to say, well, it's immoral to waste public funds by running additional studies. And some of those studies might also be interventional studies that put people at risk of negative outcomes. So this is an issue that is almost never addressed in discussions about the privacy of medical data. And it's one that I think should be addressed because from a social perspective, it doesn't really make very much sense to throw away all the information that you could know in order to protect patient privacy. So that's all I had to say. And in summary, I think there's many secrets that are locked up in administrative data that could be revealed if we had some way to access this data and also protect patient privacy. Finding new ways to make data available is in all of our interests.